Good day, I'm Dr. Irene Cacas David, and I will be lecturing on prenatal care. The source of this lecture is the 25th edition of Williams Obstetrics. Our objectives are the following. So, we will be defining terminologies. We will discuss obstetric history and how to perform obstetric examinations. We will talk about the basic diagnostic tests requested during this time, and we will discuss nutrition and vaccination. So, what does prenatal care include? So, this includes preconceptional care, meaning even before pregnancy ensues, the diagnosis of pregnancy, the first prenatal evaluation, and the subsequent prenatal visits. The American College of Obstetrics and Gynecology, together with American Academy of Pediatrics, states that a comprehensive antepartum care program involves a coordinated approach to medical care that has continuous risk assessment and a psychosocial support from preconception up to postpartum period, inclusive of the interconceptional period. How effective is a prenatal care? No? This slide shows just a few studies of how effective is it now in improving perinatal outcome. One study shows that there is a decrease in maternal mortality rate, no, and another study showed that there is a decrease in preterm birth and neonatal death associated with high risk conditions. No. On the other hand, studies showing that absence or lack of prenatal care um, resulted to an increase in the adverse outcomes such as preterm births and stillbirth rates. Okay. Ideally, this should start even before a woman becomes pregnant, so during the preconception period. So, a preconceptional care is a set of interventions that aim to identify and modify the biomedical, behavioral, and social risks to a woman's health or pregnancy outcome through prevention and management. And the following are the objectives or goals of a preconceptional care. So, to improve the knowledge, attitudes, and behaviors of both the men and the women related to preconception um, health. So, and it should assure that all childbearing age women receive preconceptional care services, including evidence based risk screening, health promotion, and interventions that will enable them to enter pregnancy in optimal health. Reduce risk indicated by a previous adverse pregnancy outcome through interconceptional interventions to prevent or minimize the recurrence of another adverse outcome and reduce the disparities in adverse pregnancy outcomes. During this time, preconception counseling cannot be overemphasized. Risk assessment is begun as early as this time. So, this is actually the best for preventive counseling. This focuses on the anticipation and avoidance of conflicts or problems during future pregnancy. Counselors should be knowledgeable regarding relevant medical diseases, presence of any previous surgery, reproductive disorders, or genetic conditions, and they must be able to interpret data and recommendations must be provided by other specialists. The evaluation includes a thorough review of the medical, obstetrical, social, and family histories. During preconceptional counseling, a thorough history taking is very important. Failure to identify a poor condition may strongly predispose a woman to poor outcome on her future pregnancy. Before you is a list that should be included during this counseling. So, if an illness is identified in medical history, then it should be explained how the condition affects the pregnancy, both the maternal and fetal effects, and how pregnancy, on the other hand, affects the medical condition. Advice for improving outcome should be provided. An example here is a type 2 diabetic patient planning to get pregnant. A preconceptional goal is to have a good sugar control. This is monitored with the serum hemoglobin A1C level. Achieving an ideal hemoglobin A1C decreases risks for major congenital anomalies and also fetal growth disorders. At the same time, explaining to them that pregnancy may worsen retinopathy in patients having this end organ damage. Studies also have shown that women who received counseling had improved glycemic control before pregnancy and during the first trimester. This group also had higher folate intake rates preconceptionally, and they experienced lower rates of adverse outcomes, which was a perinatal death or major congenital anomaly. Personal and social history should include lifestyle, work habits, and environmental exposure questions. And it's a fact also that drugs and smoking in pregnancy has been consistently associated with numerous adverse perinatal outcomes. During preconceptional counseling, information should be sought regarding reproductive history, including infertility, like if patient underwent any assisted reproductive techniques previously, or abnormal pregnancy outcomes that may include miscarriage, ectopic pregnancy, and recurrent pregnancy loss, and obstetrical complications in previous pregnancies also, such as gestational diabetes mellitus, preeclampsia, abruptio placenta, and preterm delivery. Family history should be inquired as a lot of conditions may be genetically acquired. Screening tests may be done this time, like some basic tests that are usually performed during prenatal care, no, such as screening for your rubella and hepatitis. Also, other more specific tests may be requested to further evaluate women with certain chronic medical illnesses or disease. And inquiries also on vaccination history is made, and immunizations may also be given at this time, especially those that are contraindicated during pregnancy, such as your MMR, which are live viruses. Once a woman is deemed to be pregnant, then prenatal care should be initiated with the following goals. So, we would like to define the health status of the mother and the fetus, estimate the gestational age, and initiate a plan for continuing obstetrical care. Okay, now we go to the definition of terminologies. Okay, so what is an alligravida? So it is a woman who is not pregnant or never been pregnant. Okay, a gravida, on the other hand, is a woman who is currently pregnant or has been in the past, irrespective of the pregnancy outcome. So we have the primigravid and the multigravid. A primigravid has establishment of a first pregnancy, and a multigravid has successive pregnancies. A nullipara is a woman who has not completed a pregnancy beyond 20 weeks age of gestation. Okay, a primipara is a woman who has delivered only once of a fetus born alive or dead with an estimated length of age of beyond 20 weeks age of gestation. A multipara, on the other hand, is a woman who has completed two or more pregnancies beyond 20 weeks age of gestation. Okay, the numbers are not increased to a higher number if multiples are delivered in a given pregnancy. Okay, we will have an example of that later. Okay, a parturient is a woman in labor, and purpura is a woman who has just given birth. LNMP or LMP is the last normal menstrual period. A PMP is past menstrual period, meaning this is the menses preceding the LMP. Okay, and we have the obstetrical score and the age of gestation and the estimated date of confinement or delivery. This is the EDC or the EDD. Okay, now let's go to the obstetrical score. Obstetrical score helps a person know about the patient's obstetric history simply at a glance. Okay, so we have here the G, just gravida, followed by the number, and P is your para, followed by a number. And then within the parentheses, we have four numbers as well. Okay. Um, G again is for the number of pregnancies. P is the parity for the pregnancies who went beyond 20 weeks age of gestation. And then the first number here, as you can see there, are for the term births. And then the second number is followed by the preterm births. The third one is for the abortions or blighted ovum, the ectopic pregnancies or the HMOL. And then the fourth number there should be for the living children. Okay, we have an example here. So we have here gravida 1, para 1, 1001. What does that obstetrical score mean? It means that patient had one pregnancy and para 1 pregnancy that went beyond 20 weeks age of gestation with the first number, one term birth. There are no preterm births, no abortions, with one living child. Okay, the next one is a G3P1 1011. What does that mean? So this woman has been pregnant for three times. Para one pregnancy went beyond 20 weeks. So that pregnancy ended in a term birth. The number one in the first blank. Okay, there's no preterm birth. There was one abortion and one living child. So what does the G3 means? The G3 means that she is presently pregnant because the G2 already stands for the one term birth and then the one abortion. And the G1 means now that the patient is presently or the woman is presently pregnant. Okay, so the following are examples of obstetric scores. So let us now interpret them. Okay, so for G for P4, what does that mean? 4004. Okay, so this means that that the woman has been pregnant four times, with four pregnancies going beyond 20 weeks age of gestation. There were four term deliveries, no preterm, no abortion, or HMOL or ectopic, or blighted ovum, and she has four living children. Okay, the next one, a G3P2, 2012. What does that mean? Okay, G3 means she had three pregnancies, with two pregnancies going beyond 20 weeks age of gestation. She had two term deliveries, no preterm, one abortion or ectopic or HMOL, and two living children. Okay, the next one, a G4P3, 2113. Okay, G4, four pregnancies. P3 or para 3, three pregnancies that went beyond 20 weeks age of gestation. Okay, for the score within the parentheses, so that's 21132 means there are two term deliveries. The first one means there's one preterm delivery, and one abortion, and three living children. Another example is your G1P1 2002. What does that mean? Okay, so G1 means one pregnancy, with one pregnancy that went beyond 20 weeks age of gestation, with two term deliveries, no preterm delivery, no abortion or ectopic or HMOL, with two living children. So what does that mean? Okay, so this is a twin gestation, no? Meaning, because your inner score would reflect the births. Okay, so term births. How many term births did she have? She had two term births. Okay, but the pregnancy was only one. So that is a G1P1 2002. Okay, another example. Okay, the last example is a G2P1 1001. Does that mean? Okay, so this is G22 pregnancies with one pregnancy that went beyond 20 weeks age of gestation, one term delivery, no preterm, no abortion, and one living child. So the G2 means one of that is that she is currently pregnant. Okay, so the mean duration of pregnancy from the first day of LMP is very close to 280 days or 40 weeks. No, so we customarily divide pregnancy into three trimesters, and that is approximating 3 months per trimester. So the first trimester extends through 14 weeks, and then the second is from 14 weeks to 28 weeks age of gestation, and the third one is from 29 to 42 weeks age of gestation. Precise knowledge of the gestational age is one of the most important aspects of prenatal care because several pregnancy complications may develop and the optimal treatment will actually depend on the fetal age. Okay, so let's now go to the computation of the age of gestation. So, in a reproductive woman who is regularly menstruating with no hormonal problem or uh, no medical conditions that has affected the menstrual cycle, or she wasn't on any contraceptive method the past month or two that would disrupt the normal cycle, then using the last normal menstrual period is a very reliable way of determining the age of gestation. Okay, so how do we ask for the last normal menses? So I usually ask my patients in the clinic the first day. So I ask them, Mami, kailan yung unang araw ng huling regla ninyo? Okay. And then, for example, if the patient tells you, no August 1 po. And then I would still follow it up with a question, kailan po natapos? So from August 1 po, kailan po natapos yung regla? Then some patients would say, ayun na po yung huling araw. Yun. Precisely that's the point. Because sometimes they would be confused. They would give you the last day of the LMP. So, if she'd say that, and then you ask her again, so, kailan po siya nag-umpisa, mami? So, she probably should tell you July 29 or 30. Then use that as the first day of the LMP. But some patients naman would say, natapos po mga August 5. And then you use the August 1 for the first day of the last menses. Okay, so you don't always assume that the date they give you is the first day of the last menses. So you have to probe further. Okay, so for August 1, 2020, I would like you to compute for the age of gestation manually. Okay, I know there are a lot of available applications now, especially in our smartphones now. It's downloadable, very accessible. But then again, when we have examinations, you won't be able to use your phone. So we will be asking you to compute it manually. So I'd want you to learn to compute it manually. Okay, so for August 1, okay, we will compute the age of gestation for all these age of gestations um, as of November 17. Okay, we will use this date, November 17, 2020. Okay, so for August 1, 2020, how do we do it? So that is 31 days. August has 31 days. So that is 31 minus 1. So that is 30. And then you add in the remaining months until you reach November 17. Okay, so that is 31 minus 1 for August. So that is 30 plus September. How many days does September have? 30. So 30 plus 30, 60. And then add in October. So plus 31 days for October, that is 91. Okay, plus 17 because up to November 17. So that is 108. So 108 divided by 7 days in a week. So that would give you 15 weeks and 3 days. Okay, okay, let's do it again. For May 19, 2020. Okay, so May 19, that is, May has 31 days. So 31 minus 19. Okay, and then you add in the remaining days. Add the days of June, July, August, September, October until November 17. So plus 17 days for November divided by 7 days, that would be 26 weeks. Okay, same thing for February 1, 2020. Okay, the difference is just that 2020 is a leap year. So that is 29 minus 1 for February. And then add the remaining days of the succeeding months until you reach November 17. That would be 41 weeks and 3 days. Okay, in cases where patients are not sure of their menses or they have irregular menses, um, and one way of basing or determining the age or uh, establishing the age of gestation is using an early ultrasound. So, if a patient brings in her early ultrasound, which shows that early ultrasound or ultrasound done at less than 20 weeks age of gestation. So for example, she had an ultrasound done at September 4, 2020, and then the ultrasound shows that there is a fetus measuring 10 weeks and 3 days. Okay. Um, Using this, we can now compute the age of gestation, and we will use the early ultrasound as the basis for the age of gestation. Okay, so when we have that, so September 4, compute it using the date when the ultrasound was done. So for September 4, so that is 30 minus 4, that's 26, plus the days of October, 26 plus 31, so that is 57 plus 17. Okay, for the November. So that is 74 divided by 7 weeks. And I think you'll get there at 10 weeks and 4 days. So that 10 weeks and 4 days, you add it now to the 10 weeks and 3 days shown in the early ultrasound result. So that would give you 21 weeks age of gestation. Okay? All right. Okay, so let's now go to the expected date of delivery or confinement. Okay, so once we've established the age of gestation and we have used the last menses as a basis of this age of gestation, then we can now use the Nagel's rule for our EDD. The EDD is the 40th week age of gestation. So Nagel's rule is um, adding 7 days to the first day of the last menses, and then we count back 3 months. Okay, so that is for the EDC. Okay, so for August 1, 2020, that would be 7 plus 1 for August 1, that is 8. And then you count back 3 months. So that is May. So the EDC would be May 8, 2021. Okay, Same thing. Okay, for May 19, 2020. Okay, so what is the EDC of this patient? So 19 plus 7, so that is 26, and you go back 3 months, so that is February 26, 2021. Okay, for February 1 to 2020, okay, so that would be November, right? You go back a year. So November, December, January, Feb. Okay, so November 8, 2020. Okay, and for September 29, 2020, that would be July 6, 2020. Because you would go beyond the month here, you would go beyond September 30. So that is 29, 30. Then you now go 1, 2, 3, 4, 5, 6. And then for the month, you just go 2 months back because you went beyond the month already. So that is July 6, 2020. As I have mentioned earlier, it is very important that the age of gestation is established in all pregnancies, no, because several pregnancy complications may develop at a certain time of the pregnancy, and of course, optimal treatment will depend largely on the fetal age. Okay, so in cases where the LMP is unreliable, a first trimester sonographic assessment is a good, accurate means of fetal aging. So, the structure seen in a first trimester scan is usually your gestational sac, that's the black thing there, and your embryo. Okay, the gestational sac is measured, and you come up with a mean sac diameter, and then the embryo, also the length is taken to get the crown rump length. Okay, the crown rump length is the most accurate method for determining gestational date, especially at 6 to 12 weeks age of gestation, because during this time there is very little biologic size variability. Okay, we have here the image of an embryo, no, just showing how the crown rump to length is measured during the first trimester, no, um, at different age of gestation with the corresponding sonographic pictures below it. So the first one is an embryo of about 6 weeks age of gestation, no, and the second is at about 7 weeks age of gestation. You can see there's a black um, the one with a cross mark, no, there's a black thing there, that's actually where the head is, that is the rhombencephalon. Okay, the third picture is an embryo of about 8 weeks age of gestation, where you can see it more distinctly now, the rump, the crown and the rump, the head is there. You can also see limb buds appearing already. And the fourth picture is a fetus already at about 12 to 13 weeks age of gestation, where you can see the limbs are already developed. Okay, during the second and third trimester, using this to age the fetus would be less reliable since fetal growth may be affected already by the intrinsic growth potential. Now, also if there would be other medical conditions and environmental factors that may affect the growth, causing it to either uh, get much bigger or may also inhibit growth. Once the age of gestation has been established using the crown rump length in the first trimester, then the age of gestation should never be changed. Meaning, if there is a discrepancy between the established age of gestation of the patient and the result of an ultrasound done later, then fetal growth problem should be considered, which could either be a fetal growth restriction or a large for gestational age. So if you will order just one ultrasound for a patient, do it at 16 to 20 weeks age of gestation. One, to establish correct age of gestation, and at the same time, the sonologist can identify any structural abnormalities because fetal structure will be more visible during this time. It is also recommended by the RCOG that an ultrasound to confirm gestation should be offered before 20 weeks age of gestation, as this one would reduce the need for induction for perceived wrong aging of pregnancy, especially when the pregnancy is thought to be post term. Okay, so we determine the age of gestation based on the last normal menstrual period. However, if this is unreliable, then we use the ultrasound. No, ideally the first trimester ultrasound to establish the age of gestation. However, when we do not have the benefit of these two, then we have other ways or methods of determining the age of gestation. They may be less inaccurate, but they may help us also determine the age of gestation. Okay, we have the fundic height, which we know would approximate from 20 to 34 weeks age of gestation. However, there are certain limitations, like if a patient is obese or presence of polyhydramnios or medical conditions that would predispose a patient to bigger, smaller babies. Okay, another way is determining the quickening. Okay, primigravid have quickening at about 18 to 20 weeks age of gestation, and multigravid would feel the baby's first movement at about 16 to 18 weeks age of gestation. The recommended components of the initial prenatal visit are as follows. So, risk assessment should be done during this time, looking thoroughly into the history of the medical, obstetrical, genetic, and other psychosocial factors. The age of gestation should be established. A thorough systemic physical examination should be done. Laboratory tests that will be requested for pregnant women should be discussed with the patient and the purpose of each. And of course, patient education is included as well. Okay, so the risk assessment is carried out by doing a thorough history, taking medical history. No, you look at the presence of any disease, no, of the patient, illnesses, medical illnesses? Are there any medications being taken? What were the previous laboratory results or any biopsy results for a previous surgery? No, so the surgical history as well. What were the procedures performed and then the biopsy results? Okay, you ask for the family history. Are there any other medical illnesses in the family? Presence of diabetes, hypertension, history of cancer, okay, that may have genetic predisposition. No? Birth defects also, like are there any congenital heart disease, no, in both sides? Um, Presence of cleft lip and palate. Okay. You have to take a complete obstetric history, no, with emphasis on presence of adverse outcome during the previous deliveries. No? So, for example, you have to write there all of the pregnancies and what were the outcome of each pregnancy. When did the patient deliver, or was it a live birth or a stillbirth? Okay, was it term, preterm, or abortion or ectopic pregnancy? Where did the patient deliver? Is it in a hospital, in an institution, or was it a home birth? Were there other complications during that time? Medical complications? Was it complicated with gestational diabetes or preeclampsia? Okay, or if for cases where you have stillbirth, um, you ask for the causes of the fetal death in utero. It would also be ideal that you ask for death certificate of the baby to be able to get a very, very thorough history of the previous poor obstetric outcome. Okay, so the manner of delivery should also be stated. Is it a vaginal delivery, a cesarean delivery, and if it's cesarean, for what indication? Okay, so you have to put there all the obstetric history, and then you have to put the gravidity of the present pregnancy. Okay. And for the menstrual history, identify any gynecologic disease. No. So this time also you ask for the menstrual period, the last menstrual period, and the past menstrual period. You check if it would be a reliable basis for computation of the age of gestation. Okay, so you include here the use of contraceptives as well. An important part of history taking is doing the psychosocial screening. These are non biomedical factors that affect mental and physical well being, such as barriers to care, communication obstacles, the nutritional status, the desire for the pregnancy, any intimate partner violence, depression. Also, ask on the use of substances such as tobacco, alcohol, and illicit drugs. As we all know, smoking poses great obstetric risk, no, such as placenta previa, abruption of placenta, and premature rupture of membranes. Infant risks as well, causing preterm labor and delivery, low birth weight, and sudden infant death syndrome. And these are the several pathophysiologic mechanisms behind it. Alcohol intake may cause prenatal and postnatal growth deficiency, mental retardation, behavioral disturbances, atypical facial appearance, congenital heart disease, and brain anomalies in the baby. So, alcohol drinking is absolutely prohibited during pregnancy. In fact, there are no studies showing a threshold of allowable amount. Okay, the use of illicit drugs has its share of adverse pregnancy outcome as well, such as fetal growth restriction, low birth weight, and drug withdrawals are observed among infants after delivery. There may be violence also within the relationship, no, with pattern of assaultive or coercive behavior, and these are associated with adverse outcomes such as preterm delivery, fetal growth restriction, and worse is perinatal death. No, so the psychosocial screening should be done regularly, at least once in every trimester, no, to be able to identify important issues and be able to decrease the adverse pregnancy outcome related to it. We now go to the physical examination. A complete systemic physical examination should be done at the initial prenatal encounter. Vital signs are taken, the baseline weight recorded. And so a PE should be done in an organized or systematic manner, from head going down so that you're able to touch all the other organ system. But the focus will be on the abdomen, which we will go into a detailed discussion later. Pelvic examination is performed also as part of the initial evaluation. So you ask your patient to lie down and the patient assumes a lithotomy position. Okay, and then you do your inspection first. Inspection is when you do your speculum examination. Okay, so speculum is inserted and then you observe or check for the bluish red hyperemia of the cervix, which is characteristic of pregnancy. You check for presence of any cervical discharge, and a pap smear is done during this time. After inspection, we go to the palpation, where we do our digital pelvic examination or the bimanual examination with the dominant hand using the index finger and the middle finger. The following are assessed. Now you check for the consistency, the length, and the dilatation of the cervix. Okay, check for the uterine size, palpate the adnexa, check the bony pelvic structures, and see if there are any other vaginal or perineal anomalies. We now proceed with the abdominal examination. Okay, so before making patient lie down, make sure that she has emptied her bladder. Well, ideally, since this is a continuum of your pelvic examination, the patient should have emptied her bladder even before the speculum examination. Okay, so from the lithotomy position also, you may now instruct her to straighten her legs and let it lie flat on the bed, or it may be slightly flexed at the knees to have a more relaxed abdominal muscles. Okay, so we now proceed with the inspection. You check for the skin on the abdomen, presence of linea nigra at the mid-abdomen. It's a vertical line extending from the upper part of the symphysis pubis going to the infraumbilical area. Check for presence of any scars and evidence of previous surgeries. Okay, now after inspection, proceed with your abdominal palpation. First is we get the fundic height. Okay, the fundic height again, no, as I've mentioned earlier, at 20 to 34 weeks of gestation, the height of the uterine fundus measured in centimeters correlates closely with gestational age in weeks. This measurement is actually used to monitor fetal growth with an acceptable measurement of plus or minus 2 to 3 centimeters for a certain age of gestation. This is measured along the abdominal wall from the top of the symphysis pubis to the top of the fundus. Here, you have there, you can see you have two pictures, no? One is the one on the left and the one on the right. Okay, if you can see the one on the left, the examiner measured it, the right hand, okay, um, from the top of the symphysis pubis, that's right, no? Going along the abdominal wall up to the fundus. But if you can see here, the left hand is actually measuring it the wrong way. You don't approximate the whole length of the abdomen up to the fundus. The proper way is, if you look at the second picture here below, if you can see that left arm or left hand of the examiner, it is only approximating the top of the fundus. And if you can see the measuring tape going through the index and the middle finger of the examiner. So, hindi niya mineasure from the top up to the end, as you can see in the upper picture or in the left-hand picture. Now, from the symphysis pubis to the top end of the uterus. So, the ideal or the right way is the left hand approximates the top part of the fundus and just let the measuring tape pass through the index and the middle finger. There. So that is the proper way, the second picture. Let's now go to Lupolt's maneuver. Lupolt's maneuver is determining the orientation of the fetus through abdominal palpation. Okay, we have discussed this early on, now instructing the female or the patient to empty her bladder before performing the maneuver. And woman is in a supine position with abdominal muscles relaxed. So the legs should be straight or knees slightly flexed. And then drape the patient. Explain to the patient the procedure that will be done. Okay, make sure that your hands are warm before coming in contact with the patient's abdomen. Okay, and performing this examination, the examiner should stand with the body facing the patient during the first three maneuvers and then facing the feet of the patient during the final maneuver. In doing the abdominal examination, the tips of the fingers and the palm are used. Okay, so the fingers should be together. Okay, so in Lupolt's 1, we determine what fetal pole occupies the fundus. Okay, so it could either be the breech in a longitudinal lie, it could either be the breech or the head, so breech or cephalic.
If it's a breech, you would palpate large and nodular masses. Okay, if it's cephalic, no, or if the head occupies the fundus, then that is a hard and round ballotable mass. Lupol's 2 is palpating for the fetal back and fetal extremities. So the palms are placed on either side of the mother. So a hard resistant structure is the fetal back. And if you feel small, irregular mobile parts, then those are the fetal extremities. For Lupol's 3, determining what is the part that occupies the symphysis pubis area, just above the symphysis pubis. Or with this, you may be able to determine the presenting part of the fetus. Okay, so Lupol's 3, you grasp the lower portion of the abdomen just above the symphysis pubis using your dominant hand. Okay, and it's the same thing. If it's a hard ballotable mass, then that's a head. So that is a cephalic presentation. You're able to feel this if the presenting part is not yet engaged. Lupol's 4 will tell us if the presenting part is engaged or not. So this time, the examiner faces the mother's feet and with fingers of each hand exerts deep pressure into the pelvic inlet axis. If during the examination the fingertips would meet near the symphysis pubis, then that means that the presenting part is not yet engaged. However, if during this maneuver you would feel that and that one of the examining hand would stop at some point, then that means that the head or the other presenting part is already engaged. Let's now go to the fetal heart activity. The normal rate is 110 to 160 beats per minute. So as early as 6 weeks age of gestation, the fetal heart activity would be visible using a transvaginal ultrasound. Okay, but on pelvic examination, abdominal examination, fetal heart activity can be appreciated only at about 12 weeks age of gestation with the use of a handheld Doppler equipment. Okay, and when we use our traditional stethoscope, this would be at around 20 weeks age of gestation. Certain laboratory tests may help assess the risk for and prevent some pregnancy complications. So these include basic tests that are usually performed during prenatal care. We have the complete blood count. It's important to look at the components of the CBC, especially the hemoglobin, the platelet count, and the WBC. The request for the blood typing, the RH status, is very important because in RH negative mothers, we give immune globulin to prevent RH immunization. You do your screening tests for syphilis, hepatitis B, and rubella if these were not done during the preconception yet. Urine culture is also requested, and screening for diabetes using fasting blood sugar or the HbA1c. Pap smear should also be performed when doing the initial pelvic examination. We may also request for HIV screen. The Institute of Medicine recommends universal HIV testing with patient notification and right of refusal as a routine part of prenatal care. So if a woman declines testing, then this should be written in the prenatal record. With subsequent prenatal visits, the recommended interval is every 4 weeks until 28 weeks, then every 2 weeks until 36 weeks age of gestation, and weekly thereafter. WHO actually recommends that among low risk patients, 4 prenatal consults would suffice, once in the first trimester, followed by another one at 26 weeks, then 32 weeks, and the last one at 38 weeks age of gestation. So during each visit, a risk assessment is done every time. So you ask the mother for any new signs or symptoms. The vital signs are taken, the maternal weight is recorded and compared with the previous weight. Fetus is the fetus is monitored. No? So you do your abdominal examination, palpate and approximate the size of the fetus. The fundic height is obtained. Listen to the fetal heart rate and palpate for the presenting part. So at 15 to 20 weeks age of gestation, maternal serum alpha fetoprotein and cystic fibrosis screening is recommended. Actually, this one in um, other countries. Locally, we don't request for this or we don't screen this because of the low incidence of cystic fibrosis. At 24 to 28 weeks, among Filipinos, this is universally done among Filipinos, screening for gestational diabetes. Also, hemoglobin hematocrit again is requested during this time as we know that physiologic anemia happens at around this age of gestation. For Rh negative women, immune globulin is given to prevent alloimmunization. Okay, and beyond 28 weeks age of gestation, for those who are high risk, screening for syphilis, chlamydia, gonorrhea, and group B streptococcus culture are done. However, in women with complicated pregnancies, for example, those with uncontrolled diabetes or those with twin gestation, these would often require return visits of 1 to 2 weeks intervals. And of course, you would always advise patients that if they have any new concerns, then they would consult immediately. At each return visit, the well being of the mother and the fetus are assessed. So for the fetus, we listen to the heart rate, we monitor the fetal activity, we ask the mother for the subjective fetal movement. The presenting part is palpated on abdominal examination. The size is estimated and you compare it with the present age of gestation and also approximate it or compare it with the previous assessed size on the during the last consult. And if it's possible, also monitoring the amount of the amniotic fluid. The last one is um, determined or monitored by using the abdominal ultrasound. Now, and actually, even for the size, if you would want an actual or a more accurate change or monitoring of the size, then an ultrasound would give more accurate findings. Maternal monitoring includes getting blood pressure and weight every consult, and this is compared with their previous measurements. The mother is asked for signs and symptoms, especially the 10 danger signs of pregnancy, which are headache, blurring of vision, abdominal pain, nausea and vomiting, vaginal bleeding, vaginal fluid or watery vaginal discharge, dysuria, fever, edema of the face and the hands, and decreased fetal movement. Also, during late pregnancy at 37 weeks onwards, then a digital internal examination is done. And this would assess the cervical consistency, the dilatation, and effacement. It would also confirm the presenting part and check also the fetal station. At the same time, you're able to clinically assess the maternal pelvis. We repeat the CBC, particularly the hemoglobin and hematocrit at 24 to 28 weeks of gestation, because as you've learned in your physiologic changes, there is physiologic anemia at around this time because of the increase in the plasma volume. The definitive screening also for diabetes, which is 75 grams OGTT, is done at 24 to 28 weeks age of gestation. And for women who are Rh negative and are unsensitized, should have an antibody screening test repeated at 28 to 29 weeks because if they remain to be unsensitized, an anti-D immune globulin is given. The Institute of Medicine and National Research Council revised the guidelines for weight gain in pregnancy, and this continues to stratify suggested weight gain ranges based on pre pregnancy BMI. So, if you can see here, for those with low BMI, the underweight, the recommended weight gain the whole pregnancy is 28 to 40 pounds, which is 12.5 to 18 kilograms. And for those with normal BMI, it's 25 to 35 pounds. For the overweight, with a BMI of 26 to 29, that is 15 to 25 pounds. And for obese patients, the weight gain should at most be 15 pounds. The recommended dietary allowance serves as a guide to the acceptable amounts that can be taken. Certain prenatal vitamins and mineral supplements may lead to in excess of the recommended allowances. Moreover, the use of excessive supplements, which often are self prescribed, has led to concern regarding nutrient toxicities during pregnancy. Those with potentially toxic effects include iron, zinc, selenium, vitamins A, B6, C, and D. That's why ideally we stick to the recommended dietary allowance. If it's more than that or more than twice, then this should be avoided. Here is the recommendation based on the National Research Council for the daily dietary allowance during the non-pregnant, pregnant, and lactating period. Prenatal vitamins and mineral supplementation. The routine multivitamin supplementation is not recommended unless maternal diet is questionable or she is at nutritional risk. Um, and these are the following: when she has multiple gestation, as she would need more nutrients. If patient has been on substance abuse, she's vegetarian, epileptics, and with hemoglobinopathies. Pregnancy requires an additional 80,000 kilocalories, mostly during the last 20 weeks of gestation. To meet this demand, a caloric increase of 100 to 300 kilocalories is recommended during pregnancy. And this is in an incremental pattern as pregnancy progresses. With the exception of iron and iodine, practically all diets that supply sufficient calories for appropriate weight gain will contain enough minerals to prevent deficiency. Iron, established that as little as 30 milligrams of elemental iron, which can be supplied as ferrous gluconate or sulfate or fumarate, and taken daily throughout the latter half of pregnancy, provides sufficient iron to meet pregnancy requirements and protect pre existing iron stores. Iron may be started at the start of second trimester, and especially in patients who have excessive nausea and vomiting during the first trimester, as this may aggravate this condition. It is advised that it's taken ideally at bedtime on an empty stomach. The iron dose is also doubled in cases of twin gestation or if it is taken or started during the late pregnancy and if patient has been on irregular intake of iron and she has a low hemoglobin baseline. The use of iodized salt in bread products is recommended during pregnancy to offset the increased fetal requirement and maternal renal losses of iodine. Severe maternal iodine deficiency predisposes offspring to endemic cretinism, which is characterized by multiple severe neurologic deficit. The recommended iodine daily is 220 micrograms per day. With vitamins, just like minerals, so increased requirement during pregnancy can be supplied by any diet with adequate calories and proteins, except for the folic acid. Folic acid supplementation can lower or decrease neural tube defect risks, and since nutritional sources are insufficient to provide this, the recommendation is to take 400 micrograms per day from periconception to early pregnancy. This is recommended to all women capable of becoming pregnant throughout childbearing years. The dose increases to 4 milligram per day for those who had poor obstetric history, those who had a history of a previous baby with CNS defect. And this is consumed as a separate supplement from the other multivitamins. And in ideal, it should be started pre-conception at least a month before conception and up to the first trimester or the first 13 weeks. Pregnant patients are advised to have a well balanced meal. The iron and folate supplementation during pregnancy, and again, um, advising on the adequate weight gain during this time. So this one would depend on the pre-pregnant BMI, and in a normal BMI, the recommended is about 25 to 35 pounds. Let's now go to immunization. The current information on the safety of vaccines given during pregnancy is subject to continuous change. So, if you would like to see changes later on, then you may go to the Center for Disease Control and Prevention website. Current recommendations for immunization during pregnancy are summarized in this table. Important to note here that if you can see the live virus vaccines, these are contraindicated during pregnancy. It includes here the MMR or your measles, mumps, and rubella, and your varicella zoster. The ones acceptable during pregnancy are your flu vaccine for influenza, so all pregnant women may be given this regardless of trimester, especially during the flu season, and this is given yearly intramuscularly. Your hepatitis A and hepatitis B for pre exposure and post exposure for women at risk also for the infection. Tetanus toxoid may also be given during this time, especially for those who haven't had the primary series yet. So, a primary series includes 3 shots. The first 2 doses are 1 to 2 months apart, and the third dose is 6 to 12 months from the first dose. One of this dose, you may substitute your Tdap or the tetanus, diphtheria, and the pertussis vaccine. The Tdap is recommended to be given at about 27 to 36 weeks age of gestation to maximize passive antibody transfer to the fetus, especially the pertussis part of the vaccine. So the Tdap shot is also given every pregnancy. Okay, let's now talk about some common concerns during pregnancy. Okay, let's talk about exercise. So, women who are used to aerobic exercise before pregnancy may continue during pregnancy provided that they do not become excessively fatigued or they don't risk injury. So, examples of safe activities are walking, um, swimming, stationary cycling, and low impact aerobics. However, they are contraindicated in certain conditions where limitation of activity is encouraged more, like in those with hypertensive disorders, multiple gestation at risk for preterm labor, and those with severe heart disease. Once you have ruled out contraindications, then they are encouraged to engage in regular, moderate intensity physical activity for at least 150 minutes each week. However, they should refrain from activities with a high risk of falling or abdominal trauma. Okay, any occupation that subjects the gravida to severe physical strain should be avoided. Adequate periods of rest should be provided, It seems prudent also to advise women with prior pregnancy complication that commonly recur to minimize physical work. Okay. How about traveling? So, traveling has no harmful effects on pregnancy. It is actually safe to fly up to 36 weeks of age of gestation, but limitations are actually set by different airlines. Okay, the greatest risk, however, that you may encounter with travel is the absence of facilities when complications arise. To prevent also um, development of venous thromboembolism uh, within the lower extremities, then it is advised that you have an every hour or every 2 hours ambulation within the vessel. How about bowel habits? Constipation, again, also is a common concern, no? Because of the prolonged transit time and because of the uterine compression of the bowels. And treatment may be you advise patients to increase their fluid intake. Exercise may help also, and the bulk forming laxative. Coitus, not harmful in healthy pregnant patients. However, it is avoided where you have cases of threatened abortion or threatened preterm labor and in placenta previa. Intake of caffeine. There's no evidence of increased teratogenic risk, but there has been studies that shows that during the first trimester, there's an increased risk of spontaneous abortion, especially in those who take more than 5 cups per day. There is no association of uh, moderate consumption with low birth weight, fetal growth restriction, or preterm delivery. However, it is recommended that the caffeine intake should be less than 300 milligrams per day. Nausea and vomiting. Again, it is a common symptom during the first trimester, and this is because of the increased level of the hormone of pregnancy, particularly the HCG. So, what do you tell your patients? You advise them to have small, frequent feedings and avoid precipitating factors. Hyperemesis gravidarum, on the other hand, is a severe form of vomiting that results to dehydration, electrolyte, and acid base abnormalities. Backache. Most of pregnant women, this is increased with the duration of gestation. Physiologic change, also the musculoskeletal changes tend to have an increasing lordosis and would have muscle strains around the spine. Additional risk factors could be a prior back pain, obesity as well. And so you advise patients to have moderate exercises. No, they may have back support also and avoid high heeled shoes. Okay, varicosities. Aside from the genetic predisposition of patients to develop this increase in femoral venous pressure. This may be exaggerated by prolonged standing, pregnancy, and advancing age. So, this is worsened by advancing pregnancy, increasing the weight, and prolonged upright position. So, treatment is periodic rest with elevation of the legs, elastic stockings. Um, there may be cases where surgery is advised, however, this is contraindicated during pregnancy. Hemorrhoids, another common concern during pregnancy, and this is due to the increased pressure in the rectal veins, due to the obstructed venous return by the large uterus, and also associated with constipation during pregnancy. They may have topical anesthetic for the pain, advised hot seats bath, and stool softeners also. Heartburn. This is one of the most common complaint. No? This is secondary to the reflux of gastric contents into the lower esophagus. Um, in pregnancy, this is because of the upward displacement and compression of the stomach by the uterus, and coupled with the relaxation of the lower esophageal sphincter. So again, you advise patients to have small, frequent meals and avoid bending over or lying flat right after a meal. Antacids may help as well. Pica is the craving for strange food or non-food. These are usually it may be ice or starch or clay, and this may contribute to iron deficiency in some cases. Thialism, where there is profuse salivation, there's stimulation of the salivary glands by the ingestion of starch, and however, most of these are unexplained. Fatigue or the feeling of tiredness gets better by the fourth month of gestation. This is secondary to the progesterone effect. And headache, also, which is common in early pregnancy, may be secondary to the progesterone effect. Well, it may be also because of idiopathic causes, and this usually disappears by mid pregnancy. Leukorrhea or the increased vaginal discharge may be due to hyperestrogenemia during pregnancy. So this may be physiologic, but we have to rule out pathologic causes as well. Okay, so in summary, a pregnant woman can travel, she may exercise and have sex, all in moderation. Of course, she can't smoke, can't drink, and with regards to coffee, advise her to avoid it during the first trimester. And if she may replace it with another drink. However, if she can't take coffee, then you have to advise her on the maximum amount that she can take. A pregnant woman also normally may get nauseous, constipated, and fat, with frequent heartburns, backaches, and hemorrhoids. So, these symptoms may be normal findings during pregnancy. However, if this is persistent and disrupts her normal activity or her daily activities, then it would be prudent to investigate further. So for my last slide, I came across this illustration and it made me smile because this is what I usually tell my patients also. So it says here that the coming 9 months will be the best time of your life. They will be a mix of smiles and some moments of strife. On one hand, you will become round, fat, and chubby. On the other hand, you will have all the attention of your hobby. So with that, I end my lecture and good day.